call the health meeting to order at 14 after 2. Councilor Hargis is going to give the invocation.
Heavenly Father, we thank you for this beautiful day you have blessed us with, for the recent rains. We thank you so much. And Lord, we just thank you for the opportunity that you've given us to come and to do the business, to take care of the business of the people. And we ask you that you'll just guide each of us to put our personal feelings aside and to look at what's in the best interest of the Cherokee people. In Jesus' name I pray. Amen.
Thank you. Miss Shelley, will you call the roll, please?
Fidel Fulbright.
Present.
Dick Lay.
Here.
Buell Anglin. Jack Baker.
Here.
Joe Bird.
Honey.
Julia Coates. Here. Jody Fishinghop. Here. Meredith Rayleigh. Don Garvin.
Honey.
Hannah Glory Jordan. Frankie Hargis.
Present.
Chuck Hoskin Jr.
Here.
Lee Keener. Curtis Snell. David Thornton.
Present.
David Walkingstick.
Honey.
Kara Callan Watts. We do have a quorum.
Thank you. The chair will entertain a motion for approval of the minutes.
Second.
We've moved in second. All in favor of the minutes as they are in the book, let be known by saying aye.
Aye.
Any opposed? Minutes are approved. And next we're down to reports, and we've got Claire Moore next with Mr. George Valuers.
Good afternoon. Our outpatient visits are still increasing. Our collections are on track to hit our 3% goal, 3% increase over last year. That was just over 15 million. We're looking at right now targeting about 15.8. So we should meet that 3% increase. We're still recruiting ER physicians. And we're also recruiting a couple of nurse practitioners and mid-levels for our urgent care. We got finalizing plans to upgrade our last X-ray room to be completely digital. The MRI should, I'm told from Oklahoma City that the paperwork's done. It should be able to go out to bid to start the dirt work preparation to install the modular building. So with that, are there any questions?
Ms. Kara Callan Watts.
Thank you, Chairwoman Fulbright. I know that at the Indian Health Service Advisory Board meeting for Claremore, there was an email from Yvette Rubidoux that was passed out talking about sequestration. Do you know how that's going to translate at Claremore? Have you been given a directive if it's going to impact services or staff or everything across the board on that cut?
We've been told it's going to be across the board for each line item. Area office is preparing a template for our budget to send out to us as to what our dollar amounts are going to be. I don't have that, or I would share that with you today.
Thank you.
But I do know, I think, one number they did throw out was contract health was going to get just under $600,000 hit.
Thank you very much, George. Thank you, Ms. Fulbright.
Thank you. Anyone else? Councilor Lane.
And thank you, Mr. Chair. And 600,000, is that annually per year?
No, that's just for this sequestration period from now for 2013 up through September 30th.
Thank you, Ms. Chairwoman Fulbright. I think that's a good point. So this sequestration hit, we don't know what it'll do on the next fiscal year, but that's an across-the-board cut only in the remainder of this fiscal year. So it's really even greater. Like if it's 5%, it's really like 10.
Yes.
Because it's last 6 months of the remaining remainder of the fiscal year.
Absolutely.
So if everything was 2 along, it's just going to be drastically cut almost. Thank you.
Thank you for that good report.
Thank you.
Cherokee Nation Health Services, Connie Davis. Didn't see you back there, Miss Davis.
Sean was hiding me. I will begin, since there was a topic of sequestration, with some information that we received from Dr. Rubidu's office. That doesn't show you exactly on our facilities, but gives you an idea of the impact of the sequestration across the board. We know at Cherokee Nation, we're looking at an impact of $8 million, of an $8 million hit to our budget. We've been planning for several months, what would we do, and the direction of the chief is do anything but cut services, of course, to the patients. So we're taking an extensive look at travel expenses, current positions. We have implemented hiring freezes and are going through each of those to determine essential versus non-essential staff. And we've been meeting with our program directors and our finance department and letting those clinics and those programs tell us what's essential versus non-essential. And I spoke with Councilman Lade a few weeks ago, and he said, well, you would think all staff in health would be essential. I certainly agree, but we've got to make a determination right now, what can we do without for 6 months or delay for 6 months so that we can continue to provide the services to our patients that are much needed. The obvious thing is we're not going to delay hiring a provider, because if we get the rare opportunity to get a physician or a provider hired, then we don't want to pass up on that. I'd just like to highlight a few things. Dr. Jones has successfully recruited a new oral surgeon. He'll be based out of Hastings. Every year we spend about $700,000 in contract health funds for these services, a lot of which Dr. Jones has discovered that we could do ourselves. So Dr. Collins has been fully credentialed at our hospital and is doing procedures there. And we anticipate huge savings to our contract health funds with his services. He's also continuing his review of unpaid dental claims from last year. And the last report I had, which is now about 2 weeks old, through May of last year, he's uncovered $670,000 of uncollected charges on Medicaid patients. And he's continuing those efforts with some of his staff in our finance department. Another big issue in the news recently was the poor dental practices or sterilization techniques with a dentist in Tulsa. And Dr. Jones immediately went back through 2006 and reviewed to make sure we had not referred any patients to that physician or that provider. We had no referrals there. And when he started in July, he began changing some policies on our sterilization process in the dental department. And if you have specific questions for that, of those kind of practices, I'll direct those to Steve. But it's an annual competency training now by all staff. So he was a step ahead of us on that, thank goodness. The last 2 weeks we had electronic health vendor review. We had narrowed the selection down to 2 companies, one called Epic, the other called Cerner. And now the people who attended all those reviews will do an evaluation of the 2 vendors, and then we'll go from there as far as choosing a new source for our electronic health record. And of course, the big thing is finding money to afford it. The bigger and exciting things, Camden Group is the group working on our feasibility study for the new hospital. We're in an information gathering phase for that, and we're about 3 weeks in now, so we're hoping, within 5-6 weeks we'll begin to have some information to give us a good direction on where to go with the hospital. We received 9 responses from A&E firms on our RFQ for the clinic expansion as far as architects, and a committee of about 11, I think, made a selection based on the criteria we had set out on that and chose the top 3 vendors. Those vendors were the architects. Anyway, they've been selected, and we're visiting with them, and the interviews will be done next week with the 3 vendors. And they're all Terrell vendors, I will let you know, that are very familiar to this group. It's going to be a busy next 2 weeks. In Salisaw tomorrow morning at 10, we have the DeVita Redbird Dialysis grand opening. We're very excited about that. So if you want to speak, please make sure I know the 2 obvious ones in the room, Ms. Fulbright and Mr. Thornton. I've got your names already. And Jack Brown this week will be, there's an open house on the 25th because it's the 25-year anniversary of our Jack Brown program. And then the groundbreaking for that new facility is Friday the 26th at 2 o'clock. Surgical Tech program open house is Thursday the 25th as well, and I think it's from 11 to 1. Busy, busy, busy month. And we've lost a provider in Jay, and Dr. Montgomery has been up there seeing patients for 2 days. And we've got a plan that he's going to work a day, and Dr. Doug Nolan is willing to go up and help us see patients in Jay to help with the significant shortage in providers that we have there.
Councilor Jack Baxter.
Yes. Are all services at Hastings Hospital available to all Cherokees regardless of where they live?
The right, yes.
Because I had a young mother of 2, who was referred by Dr. Gross of Benita. She lives in Missouri, by the way, and she said lots of good complimentary things about the Benita Clinic. She loved it. Dr. Gross referred her to the orthopedic surgeon at Hastings and for knee replacement. And when she called, she was told that since she lived out of the area, she was not eligible.
Well, I knew I should not answer that question before I heard all the story. And her services are, because she's a specialty service, they have to be, they fall into the contract health category because of the surgery's not done at Hastings.
Okay. But I thought that when we got the orthopedic surgeon, that they were doing this.
We're limited on what we can do at Hastings because of equipment and space. And so there's, if you will, minor cases we can do with orthopedics there, and then the bigger cases like a knee replacement or a lot of scopes are done elsewhere.
But
So
couldn't
it
you at
kind of-
least see the orthopedic surgeon? Get an
Yes.
appointment to see her?
Yes.
Because they would not even allow that.
Well, if you'll send me that name, and let us look into it. Thank you.
Okay, appreciate it. Thank you.
Councilor Kara Watts, you're next.
Thank you, Chairwoman. Okay, can you, I guess this is like an infographic or something?
Yes.
And I'm not quite sure that I understand it, though. Can we get it by email, by the way?
Yes,
Okay.
absolutely.
So, in terms of answering what the, I guess, the sequestration will do, so you've identified some things. I guess you said it will be delayed 6 months, and then I guess we reevaluate it based on the next fiscal year budget.
Yes.
So that means on any of the new construction, we'll have to delay that on the facilities, or is that like the, what does this translate to if I was trying to describe to a citizen who it's going to impact, maybe at the J Clinic or the Salina Clinic or somewhere?
Those construction projects should not be impacted by this because we're not receiving the funding for those construction projects from IHS.
So the 23 million in facilities on the infographic, I'm trying to translate, what does that mean then? What facilities are those?
This is for IHS wide. This is not specifically to us.
Okay, so we don't have, no one who says it makes sense.
No.
So
It's a very broad, I just wanted to make it, generalized information available to you on the impact of the budget cuts. But some of this is better explained in the email that accompanies this, so I will forward that or have someone, Shelley, send that to you.
So, because, are we still looking at, I guess, the 11 million or 8% based on our fiscal year 12 funding levels? Because I'd sent on January 16th that email, and I was still trying to translate how this is going to impact us. And this is from the January 16th email, and it looks like from committee notes, probably in December, this is what it looked like. And I think it's down to 5% on sequestration cuts.
5.2%.
5.2. So are we going to do it across, we're not going to do it across the board. What I heard you say is we're going to do it in terms of what is ever considered non-essential except for services. So it could be staff, or it could be projects delayed. But we don't know what that's going to be.
Not until we finish meeting with all of our programs and trying to determine.
Okay, and along Jack, or Councilman Baker's question, I was trying to look at the website, and it's kind of hard to navigate now. So do you have a one-pager or a patient handbook for our health services again that you can email, that's a PDF, that summarizes what our health service options are by clinic and hospital and who has what?
I don't think we do, but
Can we get that maybe?
we will work on that.
On
yes.
email, and not even, so I know some people offer hearing aids, some people don't, some people offer dentures, some people don't, or like clinics, locations.
Right.
And basically, I've got constituents, because they're only served by Claremore Indian Hospital, who has to abide by federal guidelines. They're shopping all our clinics, and they don't know where to go. So that would be helpful. And then in the report, it said crowns were being provided. Are we providing crowns? There was a reference in the dental report about crowns. And so if people are getting crowns,
It's a crown preparation.
crown preparation. But I want to clarify,
There was some
because
equipment purchased and that allowed us to make crowns. As you know, if you go to a private practice, you're going to pay about $800 for a crown. And for a fee of $200, then patients were allowed to get crowns. Well, that wasn't very popular with some of our constituents. So Dr. Jones is now looking at, if we're going to, kind of evaluating whether we're going to continue that. We've talked about, is that something we could pick up with the 5% money? And so,
well, my constituents may be very happy, even if they have to travel. So is it just suspended for now?
we're still doing it. Yes, please. Thank you.
We've actually been doing some feasibility studies on that, because they spend a lot of money on some equipment that's only being used at 2 of our facilities, Cherokee, and they currently have the equipment in Bonita, although it hasn't been put in process yet. So what we're looking at doing is having a budget at each clinic that allow our doctors to provide crowns for certain criteria, being for just cosmetics, has to be a functional issue, and allowed to be done throughout 14 counties rather than just in those 2 facilities. So we're looking at changing the way we're doing it a little bit. And in the past, yes, they had to pay $200 to be eligible for that service. And again, that brought up a lot of issues. Some people were okay with that, some weren't. We had a lot of complaints from that program. So we're looking at changing it up. Right now, they're finishing up the cases that were in line to be done, but they have not started any new cases.
Okay. Thank you. I'll be, so will we have an update by next month on the crown situation?
Maybe.
Okay.
I can't tell you for sure. So
Right.
we've been trying to
Are we
study.
aiming for next
We're
month?
aiming for getting that as soon as possible, because I'd like to have that, everybody have service independent of where they live. Because right now, depending on where you live, you get the service, but if you live somewhere, you may not be able to have the transportation there to get the service. So we're trying to make it so you're not penalized by geographic location.
Yeah, so how will you work with our Claremore Indian Hospital patients that are restricted to Rogers and Tulsa County? Especially since they'll have to travel.
Well, this will be inside of our jurisdictional boundaries, so they're
Rogers and Tulsa County are
Yeah,
inside
and
the
they're
jurisdictional
eligible
boundaries.
to go to our clinics, but they won't have to go to our clinic to get this service. It won't be something that we've contracted out. We're going to try to do it internally so we can save as much money as possible.
But they won't be excluded because they're primarily served by Claremore Indian Hospital as long as they're in the jurisdiction.
Now, as long as they live in the jurisdictional area, they're eligible for that service.
Okay.
Same thing with our dental program. As long as they're in that jurisdictional area.
Thank you, Dr. Jones. I have 2 more questions. How are the pursuit of the joint ventures with IHS going so that we could maybe recapture some of this $180 million that I thought we approved, but I guess it's $100 million on facilities or whatever is going on in operating cost?
We We want to meet with Dr. Rubadu. There were a lot of meetings the last couple of months. It was been hard to get on the agenda, and then, within the Cherokee Nation, we've had a lot of things going on as well. The plan is that we will go and Dr. Graham and I will meet personally with Dr. Rubadu and express our desires and our plans and our commitment to continuing health services and the great need, serving the great need that we have, and ask for their assistance in those ventures.
And if we don't get those joint ventures, then both the capital costs and operating costs will be totally on Cherokee Nation's dime then?
Possibly.
Okay.
Possibly.
So on your third-party collections and those things, are we on track for this fiscal year in terms of third-party revenue? Is it is it on track for what we've projected for budget?
We're over budget.
Okay.
The year's looking very good for us.
Could you add that aspect for the budgeted so that we can really have a measure on the report? Because I was trying to figure out.
I was reading over my report this morning. I thought we need to give a prediction of what does this mean? Is it good or bad? So, yes, we can.
Thank you very much. Thank you, Madam Chair.
Councilor Watts, I wish to bring to your attention that you are taking up more time than all the other counselors, and I've got 4 other people waiting, and I wish you'd limit your questions to just 1 or 2 things.
Madam Chair, I appreciate your comments, but I've been tasked to do a job on my constituents, and it's been hard to get answers to stuff when I've been taking months for emails to be responded to. So I appreciate the time we have in committee to ask these questions to do our job. Thank you.
If I haven't responded to an email, please resend it, because I think I'm as close to caught up as
Thank
I can.
Speaker?
Yes, what we could do is, if people have more than, say, 3 minutes worth of questions, we could compile those questions and give those to our department heads. Each one of us could do our own email to the department head, or have a face-to-face with the department head where they could get those questions answered for their constituents, and maybe only take, since we only have an hour, we're going to have to, unless you all want to go to multiple days. And we're here to do the people's work. If y'all want to go to multiple days, then we can figure out a schedule to spread it out over multiple days, or we're going to have to limit the questions somehow. Or
I'm just trying to be fair when I've got several other people here waiting. Okay, Dr. Junior Coach, you're next. Yes.
Well, Councilor Watts, in her very thorough and very detailed questioning, actually already addressed what I was concerned about. So I want to thank her for it, and I want to say that I think that it's important that the constituents get to see the exchange and hear the information also, not just that we get it in emails. So I applaud the deep questioning. I'm more than willing to go to multiple days if that's what it takes to
I can
to do
appreciate
this
that,
job.
but
So
there are
thank you very
17
much.
of us on here.
Yep, and many people don't ask any questions at all, so I don't
Well,
think...
maybe they don't feel like they don't have the opportunity. Okay, Chief Joe Bird, you're next.
That was simple.
Thanks for the simple discourse.
What I try to do when I'm chairing meetings, I just go 2 questions, 2 questions, 2 questions. Then if we've got time, I'll go back and redo that. And that's out of courtesy. And if we need to go multiple days, let's go for it. But, comment. I like the way at least you got ahead of the game and gave us some charts and numbers to go by. Because every report we've had today, that's been the issues, the question. How's that going to affect the budget? How's it going to affect our employees? And I just commend you for giving us a chart getting ahead of the game. And you had the largest department, the largest budget. And yet, you came across with some numbers and some information. Thank you for you and your staff.
Well, you're welcome, and I'll try to have it specific to Cherokee Nation when we come.
And thank you for hiring an oral surgeon. I'll save us some contract dollars. Thank you, Madam Chair.
Councilor Hoskins.
Thank you, Madam Chair. Just 2 questions / comments. One is on the IHS budget. It's reading the President's budget actually increases IHS funds for fiscal year 2014 to some extent. It's obviously got to go through Congress, and I know lobbying isn't your shop. Are you confident we're on top of the lobbying? Because it seems like once it gets to the House of Representatives, it hits a brick wall in which programs are gutted left and right, and I wonder, do you feel like we're on top of it?
I feel like we're on top of it, but I wish Dr. Grimm was here to speak to that because he saw that proposal and he has, he doesn't feel like the proposal is as nice as it seems. He has some significant concerns about it. And I've asked him to respond the way to this email, the way he did to me in a conversation. I'll be happy to share that with the group, or we can speak to it next committee. But I don't think our funding is going to be much better. I know it says it is, but when you get down to really narrowing the numbers down to what's real, it's not the case.
It's better than going backwards, which is what
Absolutely.
I think the House of Representatives would have us do if they get their way.
Absolutely.
So we'll see how that turns out. And then secondly, sometimes the criticism of the new clinics we're going to be constructed is, well, we didn't go after IHS dollars, more specifically the joint venture dollars. But isn't it true that there really only has been a handful of those joint venture opportunities all over the country? And in fact, maybe one or two in Cherokee Nation. I mean, I'm glad you're pursuing it, but it seems to me if we wait on IHS, we'll never get these built. We'll never get them built. But if you're pursuing them, that's great. We can come, you feel like if we could get a joint venture on the projects we've already got underway, it's possible at least.
We're hopeful.
So I applaud you. I think it's the right direction. If we, there's an economist that said, in the long run, we're all dead, and that's true. If we wait forever, we'll wait forever. So I'm glad you're doing what you're doing. Keep up the good work. Thank you, Madam Chair.
Thank you. Thank you.
Council Fisher-Croft, you're next.
Contract health. I am about at my limit with contract health. Connie, can you get somebody to go over the process? I'm getting calls left and right still on things that I have given to them 6, 7, 8 months ago.
Okay.
And it's irritating because I sit here and tell these people that we've set aside this 5%, and now they're thinking I'm lying or we've got problems over here. And I'm really tired of blaming it on you all, to be honest. But something's going to have to be done because I know I'm not the only one on this council that's had problems.
Okay. And I forward those along, and if they aren't resolved, let us know. But I think I'm going to have them develop like an algorithm so that we can educate the public on what happens in the referral process. So
I think you need to educate the problem, but I don't think it's the public because these are the ones that I've been dealing with that contract health is not handling. So I was going to maybe suggest I was going to talk to Beacon Kennedy and see if that group, self-government, internal audit, can do an audit over the processes because there is a big breakdown somewhere. And I will talk to Vicki. I guess she reports in the group this week. Okay, thank you.
Councilor Keener, you're next.
Thank you, Madam Chair. I just have a few questions. They each have 7 parts. Not on the show.
That's the problem. One question.
On your emergency care, you screen over 5,000 people a month, and you combine urgent and emergency care. And will that also include the when someone's picked up with an ambulance as well?
Yes.
And they go to Hastings first, is that right?
Yes.
And then sometimes they may go somewhere else.
Right.
Or, I can't remember the numbers you had on there. You did provide that.
Those are the patients. That number reflects the number who present for care at our hospital in Tahlequah.
Okay. And I think you've done this in the past, and this is very good, these graphs and charts like this. So if we want to apply the patient seen per month, could we see that too, maybe in a graph?
Yeah, it's in the packet.
Is it?
It is.
It's 8 page 40 here.
What page is that?
It starts with this page here.
Oh, okay. You're right, it is. Sorry about that.
That's all right.
Have you noticed an uptick in the emergency care lately? The
Emergency
trend is
numbers
going up?
always trend up, yes.
Okay. And also, one more question. I got just one comment from someone that there wasn't any interpretation service for Cherokee person that only spoke Cherokee. So they said that they were told that they could get an interpreter, but they have to do a purchase request to be able to pay somebody to do that. And I thought that surely, this was a telephone, surely someone could have helped out or, you know, in a situation like that. I mean, it's good to have someone on contract to do that, but if they have an immediate need, is there some way to address that? Or
We will look
already
into that.
have?
I'd be surprised to find that there was someone, not someone at the hospital readily available. There are
Right,
several
right.
fluent employees
Yes.
that I can think of right off
Yeah,
that
that-
could do those and have always been very willing to do that.
Well, that perplexed me too, because I know
Yeah.
that there's probably multiple people right there close by that could do that.
Absolutely.
So, but they are permitted to do that, right?
Oh, absolutely.
Yeah.
Yeah.
Okay.
That's an odd, you know, you might would expect that for a Hispanic or another, but I don't think I've ever heard of someone
Right.
not be able to find a Cherokee. So.
Oh, thank you. Thank you, Madam Chair.
Councilor Lang?
Thank you, Madam Chairman. I'll limit mine to 2 questions. Have we hired any docs out of school recently since the first of the year up till date?
We had hired about, last month, I think we had hired 9.
Out of school?
Oh, out of school, I would have to go back and clarify exactly where they were from.
I think we graduated. The reason I'm asking is I'm just wondering where they went.
Now, the residency program that's graduating this year, we've recruited 4 of the 6 graduates in our area. 4 out of 6, right?
And were they on our directed study program?
I couldn't tell you right off the bat.
And the 670,000 that we did not bring in, I think this is Dr. Jones' question that were not accounted, didn't come to our general ledger. Will this new software take care of that in addition to tying all the clinics together?
For me, I'm not familiar with the new software. I mean, I can go to Cerner Hills. Are you talking with Dentrex, with our software? Yes, we're going to be billing all of our dental codes out of Dentrex. We're getting all that set up right now, and we're actually setting up a process to be able to do that.
So on the dental side, you're going to take care of that? Or are you going to be able to tie into all the clinics also?
Yes.
Okay.
On the dental side, we're all connected to a network, and we have a process that has a lot of different parts to it that currently aren't connected. So we're reviewing and putting those connections, those bridges in place, and training our staff at each clinic on what information needs to be gathered to be able to complete that process. So we're real close. We're out actually doing the training now. We started last week. We'll be up in Benita and Jay tomorrow doing the training, and by the end of next week we'll have all the facilities, all the front desk staff trained on the information we've got together. We're working with the registration at each clinic so that we're doing a part of it in dental. The main registration happens, of course, if it's a new patient or a reactivated chart at the main registration. But all the other information that we put in Dentrex, we're gathering independently on our own because the RPMS system does not talk to Dentrex correctly. So we're kind of doing a workaround right now.
So you're running down the road getting set up to accomplish bringing these funds in that are getting away from us,
Right.
for having passed.
We're trying to put the checks and balances in so it doesn't happen again. We're going back and recuperating everything that we found. We can go back up to a year. So we started January 12th of 2012, started moving forward up through May, doing it independently, paper long, really. We have to go back and look at it each day. We're trying to put the checks and balances so it doesn't happen again.
And on the medical side, will the new software do at least as good as what his Dentrex is doing? How much will it cost? It's got to pay for itself, whatever it costs.
Absolutely.
Thank you.
I'd like to ask Dr. Montgomery to come up and explain something to us about the phasing in of the 90-day prescriptions and how it's not automatically, because there's a lot of misconceptions out there, and I just heard about it through the grapevine, and I asked him about it, and it's something that we're all vitally interested in.
What can I tell you?
Just explain to us how it's going to work.
May I preface it with a few comments?
Yes.
Our current prescription program, I think, is a very good service. We have very few complaints about it. We do have some patients that have difficulty reordering their medications, but as you know, it's a monthly service. As a monthly service, that we have numerous contracts that we're able to recoup the expenses for our medications. And Mr. Sanders helped me, but in the last few months, pharmacy has finally paid for itself, so to speak. The cost of medications and the monies that we bring in, we finally actually match them. We're breaking even. With sequestration, as you're fiscally responsible for the medications that are provided to our citizens, making a decision to offer a service, 90-day prescription refill, that would will lose us money, is a very hard decision. But it was something that was requested, it was promised to the citizens, and so through a very careful process, we've come up with a system of providing 90-day refills. It has been implemented, the providers are aware of it, but it was the feeling that this shouldn't be something that should be broadcast, so to speak, or advertised, because we didn't want to see our pharmacy services, which are functioning well, transition to something that could, one, overwhelm our pharmacists, and then two, lead to significant losses in revenue, which again we're having to deal with because we didn't want to lose that revenue with the impact of sequestration. So the service is available. It's to be initiated by the provider. In other words, citizens or patients can't just go to a pharmacy and say, I want my medications for 90 days. Your provider, if you're a patient through the Cherokee Nation and you have a provider, and you would like to be considered for the 90-day refill program, you should ask your doctor. Your doctor, I'm a little nervous, obviously, but you should ask your provider if you're an appropriate patient on the appropriate medications that should be supplied through the 90-day refill program. Examples of medications and instances where you wouldn't be eligible, and I think you'll all understand this. Pain medications. You just don't get 90 days of those. It's not a good clinical practice to give someone large amounts of pain medications. Other medications like Coumadin or warfarin that require careful monitoring, it's just not a medication that you should give somebody 90 days worth. As you heard, I've helped in the clinics this past week, and most of the patients that access our system are on a variety of medications. They're on complex regimens of medications. And I was seeing patients, and I made changes in those medications that required careful follow-up within 2 to 4 weeks. Again, it doesn't make sense to give somebody 90 days worth of medication that you're likely going to change in 2 to 4 weeks. The other thing I want to emphasize is that the current way that Cherokee Nation administers their medications involves very, very careful oversight by our pharmacists, which is unique. It's unique. It provides not only oversight, our system provides oversight from our providers, but it also provides very informed oversight from our pharmacists. So, again, as a convenience, a 90-day refill is a very good thing. But as a clinical practice, it's not always a good thing. And so, again, I want to emphasize we have a good pharmacy system in place, medication refill system in place that provides medications on a monthly basis. There are some individuals that it will benefit them for a variety of reasons. They have difficulty getting the refills. They have difficulty getting the mailbox, something like that, where they will be ideal candidates for a 90-day refill program. Does that answer your question?
Yes, sir. And I didn't mean to make you nervous or put you on the spot or broadcast it, but we live in a real world here, and half of the council is trying to get reelected, and their opponents are attacking them on this issue, that we're not producing or looking out for them, and that's why I ask you to broadcast it to the world, whether you wish to or not, because I'm not running for re-election, but I know several who are, and that is one of the issues that is always brought up against them. You took away our 90-day prescription, and we want it back, and elect me, and I'll do something about it. So you have answered this question and solved it for us, and I thank you for your time. Councilor Watts?
Thank you, Madam Chair.
Yes.
On the financial numbers, because of sequestration, those things, can we add that to the report and help monitor what those numbers are in terms if there is loss? Because I assume Medicare and Medicaid will be impacted by sequestration too, so our third-party revenue should see a loss as well.
Mr. Sanders can reinforce this, but we'll be tracking the impact of this change. And try to.
Currently are, along with that, carrying other changes through CMS also that change the payment structure from third-party payers to not just Cherokee Nation, but across the whole health system in the United States. And it reduced about 2 to 3% that amount of income automatically to us and to protocol business as well.
So do you have
So we'll get to see two pieces of that.
Thank you. Thank you.
Thank you, Dr. Montgomery. Thank you, Jeff Sanders, the pharmacy director, and all the hard work you put into it. And I didn't mean to burst your bubble by broadcasting it, but we need to know. Okay, next is old business. Discussion and possible action, the 5% set aside, sponsored by Big Black. Thank you, Ms. Davis.
Yeah, I think there are a couple of things going on here. I think it's already been mentioned for contract health services, referral services. Doesn't seem to be working like we would all like for it to work. And I'd just like to, can somebody go to work on that and get it to where I'm still getting calls? And so if I get one call, I'm guessing there's 10 more people out there that have the same problem that just let it go. And I was told the other day that, I sent some stuff in and I was told, well, we'll just have that company write it off. And when they write it off, what happens is that person then starts getting phone calls from the collection agency. The collection agency then turns it over to a bad debt and it runs the person's credit. So the comment about writing it off, it just doesn't wash. That's a very insensitive comment. Maybe somebody can't afford that. We need to try to figure out some way to make this system work. And I don't know what the problem is. You guys work there. I want you to fix it. And that's all I'm asking for. I don't think that's outside of the realm of a lot of smart people working in the health department. And I think that's about all I better say about that. And this 5% set aside, I keep gaining things to put on this. We put on last time the dentures cost. And so if somebody wants to talk about the contract health referral or the dentures and see where we're at on the cost of that, I think it was, I forget what the cost was, $700, whatever it is. And I'd like somebody to comment to us on the contract referral and why it's not working, why we don't seem to be utilizing the 5% program, when I know that we had a use for it when that legislation was passed. And the other thing about the bill is not those two. Thank you.
I understand your frustration because there's a lot of need, and then it's unfortunately not just as easy as saying yes and no a lot of times. But at the back of the health packet, there is a report that is provided monthly on the expenditures of that 5% fund. So I'll just refer you to that, but we certainly know we have room to improve our contract health system, and we'll continue to work to make sure it's more of a service to our patients.
Councilor Hoskin.
Thank you, Madam Chair, and I appreciate Councilman Lay bringing this up. And I don't know if it's the councilman's desire to keep this on the agenda, but it is something I'd like to see us keep tabs on. I get phone calls too. I know everyone on the council does. It would help me if next health committee meeting, if you could sort of, and maybe you've done this before, kind of lay out graphically how this process works, because I probably only see it when something went wrong, because that's when I get the phone call. I should have prefaced it by saying, Brett, in your office, every time I ask him to check into something, he does it and gets it done, and I really appreciate it. But it sort of brings to mind, where did the process break down? So if I see sort of graphically how this process is supposed to work, I thought I had an idea of how it was supposed to work. I thought it was supposed to work in a way that was almost seamless, where communication would be received from Claremore as to a denial or a deferral, and then that would be acted upon. But when I get the phone call, it didn't get acted upon or didn't get communicated to Cherokee Nation. And I just wonder if there's a study underway of these situations where we have to call and report these, do you look at them and see where the process broke down? That's what I'd like to talk about. I think the councilman would too.
We'll continue to work and see where the breakdown is. Most of the time it's human error. Sometimes it's on our side. It's a staff issue, or sometimes the patients haven't completely provided the information that is requested, but it needs to be better.
Very good. Thank you. Thank you.
Thank you, Madam Chair. I have on your report, you have 415 non-Cherokees that applied for the 5% CHS, and then another, I assume that's not the same people. I guess it could be the same people that are 229 that are out of area. So there were only 3 actually denied and 89 pending or pended. So can you give me an example why non-Cherokees would think that they could access our dollars? Why are we getting those referrals? Is that clogging the system? Because that's a large number.
Those are just denials. We're going to report the Claremore denials, and then drill down into each one of the Cherokee that live in the gray area. So it's just a way to separate them out.
Okay, so are we doing the same thing for the Miami Clinic denials and the Creek Nation denials that may be in, or, because I think those were the other 3. So contract health service, inpatient, outpatient in the 14 counties, Sequoia, Adair, and Cherokee, both inpatient, outpatient were Cherokee Nation Health Services. Tulsa, Rogers County was only Claremore Indian Hospital, inpatient, outpatient, but then you would have 9 that were a mix of Cherokee Nation Health Services and/or Claremore, Miami, or Creek. Is that correct?
Don't do the same with Creek. Those are all inpatients. So those are all impacting. Work in Miami, we don't.
Okay, so, and I will tell you, so it appears that Claremore is the most seamless in some ways, because you're accessing that information and there's a relationship there. But yet, that's where we're inundated with emails and phone calls that we have to harass you guys with.
It's somewhere between, anywhere between 27% to 34%. We don't want to actually go with that.
Okay. I will tell you, is there, I think we've talked about it before, but I'm trying to remember, I don't think I have it on file, a single sheet of paper that's something that's an addendum to the Claremore Indian Hospital patient handbook. That is, if you're denied, so here's how IHS and Cherokee Nation Health Services layers and boil down the policy that was signed by the chief, that eligibility, so we don't clog the system, just like our pharmacists don't want to be inundated with those phone calls. We don't want to clog, we don't want to, Brett's desk and the few staff he has inundated with phone calls. So is there something that we have at Claremore Indian Hospital or Miami that they know as soon as they're denied, they need to immediately make sure they're appealing and doing the other things that we require to access the 5% because they're outside of Cherokee Nation contract health service?
We don't have a document, but we could do one.
We're working towards to do that.
Could you, and then email that to us? And we may have, if it's okay, I don't know if it's appropriate, but if you send a draft, we may have feedback because we are obviously getting the misunderstandings or lack of knowledge about how it works. And then I heard Councilwoman Fishinghawk's concerns about the turnaround time too, and I don't know, what it takes. I don't have to do that job, thank goodness. That you guys get sainthood for that, right? So the turnarounds, it sounds like there may even be just in our general process. We've delayed them because they're relying on CIHS at Claremore to deny them. And then we have further delays maybe worked into ours, and it may not be something we can overcome. I don't know. But could we kind of lay out what that looks like and what patients should expect and how they can manage their personal credit in the meantime and stave off credit scores going down and these things that we see? Does that sound reasonable? Is it, I don't know, Madam Chair, is that something, are we going to table this for next month that would be brought up, or?
It's my intention to take a look until we start getting in.
Second.
And at the same time, they're asking about dentures and eyeglasses and all those other things. They're not seeing that necessarily at Claremore Indian Hospital. I don't know how they're finding out about it unless they actually read what we put out as council people, or they go to our meetings, or they talk to us. I don't know how they find out. The report you did in February says there's money being expended. But I don't know, there's a lot of folks say they don't know that that even exists, that they could access it. So if we can have on those other clinics similar handouts, we need that as well. Thank you, Madam Chair.
Okay, thank you, Connie. Next is something that I requested, and last month I attended a CMB advisory board meeting, and our CEO had some of his people there explaining about the changes with the healthcare delivery system, and we had chosen a different company that was going to save us quite a bit of money. And I was so impressed that he knew every detail about it, and several of the council have had calls from our employees working at the casinos and various other places who misunderstood what was going on and thought it was a cheaper program, not as good. And I just wanted Sean Slayton to come up and explain to us what was going on, and it really is better. Come on up, Sean, and tell us about it.
Yeah, I'm going to get on the phone and try to find that guy, Janelle, because it's not me. I can kind of tell you what we're doing over at CMB. We're working to move to a new program on May the 1st for our employees that will be transparent to them. They shouldn't see any difference other than they'll get a different card that basically looks the same as the card they've got. But behind the scenes, some exciting things are taking place, and I think the nation is participating to, or going to, or thinking about it, or something. But a company has come to us that has brought a unique way for people that live in the 14 counties, their services, to have a steeper discount than what we normally get just through the Blue Cross network. So what we've done is we've worked with them to move forward on May the 1st, and like I said, it should be transparent, seamless to the employees. Everybody should just go to the doctor or go wherever they want to go. But if they are a Cherokee citizen that has a card that lives in the 14 counties, then they will be the hospital, and it's hospital only. The hospital will be reimbursed at a steeper discount than what's currently been negotiated with Blue Cross and Blue Shield and the network that they're on now. So that's pretty much it. We hope that through that program and a few others that are attached to that we can generate approximately $2 million a year in savings over at Cherokee Nation businesses. I will say that in years past, you know that healthcare costs are skyrocketing everywhere. And for the most part, CMB has borne those costs via the company. We're self-insured, which means we pay every medical bill that's out there on our employees. And instead of raising rates on the employees like a lot of the other companies have to do to be able to still be able to provide insurance, we've had the good fortune of having some great years here, and the company has if you will, eaten the cost of those increases. And this, by participating in this program and hopefully it being a success, that's another way that we can offset those rising healthcare costs is by negotiating better rates with the current providers. And I'll be happy to try to answer any questions about that program.
Yes, Councilor Watts?
Thank you. I guess I'm a little bit confused. This does or does not have something to do with the tribal employee health care plan changes? Doesn't have anything to do with it?
I can't speak to what happens at the Nation.
We are changing,
Elizabeth.
well, the same company, both CMB, CNI, and
All to Blue Cross Blue Shield, or that one that just got named in the packet?
Health Smart
Health
is
Smart.
the plan administrator. The network stays the same. It's still Blue Cross Blue Shield's network. They just are administering the claims.
Okay, and everyone is changing, so that, I'm not an insurance expert, so please, the administrator is the Health Smart, Blue Cross Blue Shield is still the insurance.
Yes, they're the
provider.
network.
The network.
They've gone out and they go out and negotiate rates with hospitals and doctors and providers, and you're either in network, which means you're, as a provider, have agreed to the discounted rates that Blue Cross has negotiated, or you're out of network provider, which means that you aren't on the Blue Cross network, and that's the way it exists now, and that's the way it will exist, going forward. So, again, and this is only for the facilities. It doesn't have anything to do with your doctors or anything like that. It's only if you're an inpatient at the hospital.
That's hospital-based charges.
Do you have some kind of summary you can just provide us offline to explain? Because I thought it was always one package, or maybe it just happened to be, I guess it's got bid separately or something, or...
And we also have the people from Health Smart here if you would like to ask them any questions.
How is it suddenly disconnected? Because I thought the whole value of Blue Cross Blue Shield was they were their own administrator to help control cost, but now we've got it separate?
They can't do what we need them to be able to do, which is try to get Medicare upgrades. They aren't able to do that. They don't have the capabilities for it. So
do we not need them anymore?
we still need them for the network.
For the network. This is interesting.
And we haven't abandoned them. They have been involved in all the discussions in favor of this. So this is not something they aren't aware of. They were in favor of going.
So of course the savings then offset the additional costs we're incurring with the addition of the Health Smart layer. Okay. I don't know that I have any questions. I don't know that I know enough about it to understand it to ask questions. Is this because of Affordable Care Act changes, or just?
It's just trying to make sure that we are receiving all of the savings.
Because it looked like there's additional cost to the employees with this change too.
Not to the employees.
Okay.
Not to the employees, just to the.
Is there less services going to be provided under it? Okay.
Everything's seamless to the employee.
Okay, well, very good, because I'd heard murmurings and I didn't understand, so this is very helpful. Thank you, Madam Chair, for bringing this forward.
Yes. Madam Speaker.
I think a page in the open enrollment health period, a whole page was dedicated to letting the employees know, as well as this body, what was occurring. Is that correct? And that's
Yes, there was a letter that went out with all of that information.
And I believe that open enrollment just ended last week, didn't it?
Yes, it did.
And I think it was the first page on everybody's packet.
Yes, there was a letter, and then there was actually an information packet by Health Smart that detailed all of it.
Thank you.
Well, thank you, Mr. Slayton. The reason I invited you was we all do have the information in our packet, but several of the councilors were getting calls, and they thought, I don't know who advised them or how they got their information. They thought their benefits had been cut, and some of them thought it was going to cost us some more. And when I sat in on the board meeting, I thought it was really a great thing and savings to us.
I think in 6 months to a year from now, we'll all be glad we did it. It's just like changing any other service. There are going to be some bumps in the beginning. You're going to get a call that says, hey, I got denied this, or they're billing me for that, or something like that. But we've got plenty of people on staff, and we just want those people to forward those requests to us. We'll get them to the right people, and we'll get it worked out. There'll be several things over the first few months, and then we should start seeing things smooth out. It's new to the providers, and it's new to the patients in behind the scenes. So
Well,
it's not going to go seamlessly perfect, but we've got the resources to address the issues.
well, the reason I liked it so well was because all of the hospitals involved are going to agree to take the Medicare rate, which is considerably lower than what we had been paying. So it's a big cost savings.
That's correct.
That's the basic change, and the reason for it was to save money, so I liked it. And I thank you for your time. I know you're busy, but I don't think there's that many CEOs that know that much about all the little details of insurance like you did and explained to us. I appreciate that.
But I really don't know much. It's the people behind the scenes doing the work, Susie, Scott, and all of them.
Well, somebody put a bug in your ear, so.
They did. Thank you.
Thank you. And thank you, Miss Odell. Do we have any announcements? Oh, Mr. Keener.
Thank you, Madam Chair. Do we need to vote for the table, Councilor Lay's?
I thought he withdrew it.
No.
He wants to table it.
Second.
Okay. Motion's made and seconded to table it. All in favor of tabling it to next month?
Aye.
Aye. Opposed? Okay, we'll table it and bring it back next month. Thank you.
And I'll be glad to come in for however many meetings we need to, if we need to ask our questions and deliberate. We're going to do that.
Yes.
If I could, after this meeting, let me talk to the chairs, and we'll get back with the body on that.
The next meeting is tentatively scheduled for Monday, May the 13th at 1 p.m. Chair will entertain a motion for adjournment. All those in favor of adjournment? Aye. All opposed? We're adjourned.